Has any research been done on comparisons of the amount of money going into medical care to improve community health compared to these community public health interventions that you're telling us about?
It obviously depends on the problem you're thinking about. So take lead poisoning prevention. It was NHANES that identified a significant problem in lead poisoned children and led to the elimination of leaded gasoline and the reduction of leaded paint, and a tremendous public health success story. Far from finished. We still have significant problems, but that was directly emanating from lead paint. If you compared a public health action of eliminating lead from gasoline and paint to chelating children, obviously there's no comparison. You can't chelate when kids are generally. So what we're looking at today is something called the Million Hearts Campaign, which was launched with a public-private partnership earlier, about a year, almost exactly a year ago. This really came from a lot of the NHANES data and says that this isn't either or, community prevention or clinical prevention. This is how do you improve health as much as possible? And you do that from a combination of healthier people and better care. And both of those things are going to be important. There was a seminal article written some years back by a CDC author that looked at the decline in heart attacks and stroke deaths in the US between 1980 and 2000. Those deaths decreased by half in that 20-year period. So they were cut in half. And of that half, about half came from community prevention and about half from clinical prevention. Now it's different for different problems, and if you look at the age groups and the time course of action, it can be different, but all of those things can be assessed through NHANES. So are we treating a higher proportion of people with high blood pressure? Are we reducing the absolute rate of high blood pressure or high cholesterol in the community? And it's useful, I think, to think of them as two separate but related things, healthier people and better care. And obviously what we want to do in our health system most broadly, whatever happens, whatever state, is to make sure there's synergy in that.
Is use NHANES data in coalitions, et cetera, to understand the needs of their community, and many of them are hearing that diabetes is front on the mind of many people. And so about 75 Ys now have decided to start running a pretty intensive program called the YMCA's Diabetes Prevention Program. It's built off of about $200 million worth of NIH and CDC funded research. And this is another one of those examples where we're a part of something that CDC has developed, the National Diabetes Prevention Program. But in response to those community needs that they hear about, they make the investment to start going with this program. And it takes a lot for a Y to get going with the program, to understand how to be part of a community integrated health system. They have to understand HIPAA, they have to understand privacy rights, et cetera. It takes a while for them to kind of build referral networks, all that kind of thing. But your question was about cost, and what we've been able to show in a couple studies, one is the DEPLOY study published out of Indiana, that Ys are able to deliver this evidence-based intervention at a quarter of the cost is what's seen in clinical settings. Therefore reducing new cases of diabetes by as much as 58, 71% in an older population through a community-based lifestyle intervention.
The Diabetes Prevention Program is a great example of that interplay between clinical and community, and it's been a great partnership with the Y. As has been said, they actually cut costs by 3/4, so that the annual cost is about $400, $450 per person as opposed to $1,500 and $2,000 per person, and the results are terrific. It's a 60% or so reduction in the risk of progression from prediabetes, which would be identified by a clinical system and referred to a community provider to provide this program. And it's a great example of how clinical facilities and community facilities can work together.
Well, first of all, the response rates that we have are really tremendous. People are very, very willing to do it. And I think they're willing to do it because we explain to them what comes out of it, the importance of it. We do give an incentive for participation, but I think the incentive is in a sense by the point. They also get information from this. So when they leave that mobile exam center, they actually get a written report on some of the measurements that were taken in the center. About 6 weeks to 2 months later, they get another set of measures that come from the many, many tests that were done, say on their blood and urine that was that they donated, and then there's another round of responses that they get. So they really do get something out of it, and my sense is that they really feel that they're contributing to it. It is time. Okay, it's time in the home and it's time in the mobile exam center. But 5,000 people every year, more this year when we factor the additional sample of kids in, are very willing to do it.
The question is, how do we decide to add something? First answer is very carefully, because it is very expensive, it's complex. There was a lot of interest in youth fitness. There hadn't been a good national survey in literally decades. And with the First Lady's Let's Move campaign, there was a real desire to see what's our baseline, how are we doing, what's the status? And from that to actually implementing it, many, many steps. Can it be done in a standardized fashion? Can it be done safely? Can it be done in a representative fashion? What are the best tests to be done? What can we learn from doing it? So there's a whole process, not just on the front end of deciding what to do, but also on the back end. Once Ed mentioned, the data is all public. So in an anonymized, de-identified fashion, it's available for researchers. But in addition, there are biological specimens that are available, and there is a committee that will say, all right, if we've got excess anonymized serum and someone wants to test for a new form of hepatitis or a new way of measuring cholesterol, there's a committee that will assess and rate whether those are, what's the priority, because it's a limited resource. So I think that the basic concept is transparency, open discussion of what the reasons are. Obviously, there are resource limitations for what can be done. A technical assessment for what can be done accurately, reliably, repeated, and with replicability. Ed, would you like to say more?
Well, adding the youth fitness survey was a major decision because that was another trailer and those resources. But every 2 years, we go through that mobile exam center, in a sense, and say what's going to remain for the next 2 years, what's new. And we do that by asking our federal scientific colleagues and outside the federal system through our advisory committees for suggestions. These are all then pooled together, okay, and then we with our advisory committee consider, well, can we interrupt a particular trend, okay, by putting something else in its place, and then when would we pick it up? And it's very complex and requires a lot of balance. It requires considering cost. A significant portion of the cost comes not only from our budget, but from contributions that are made by other collaborators. But the fact that there's a contribution is not the reason that something new will get in. The real reason is that it's considered to be something that's very important in terms of public health. The word that I think is most important is it's a very transparent process. This isn't something that's made in some decisions that are made in some back room somewhere. The public health community really has a significant role in helping us to decide how to manage the resources.
So HANES has really a wealth of information. It is one of a family of surveys. It's the primary examination survey that CDC does. There are other surveys like BRFSS and National Health Interview Survey, which is an in-person interview, which will provide state-level estimates, which NHANES does not. But NHANES is the only place that reliably measures a national sample. So that would give information on consumption of food and beverages. That would give information now on fitness of kids, relevant to education. Transportation surveys, there are a whole host of things that look at different ways that transportation is done, but the in-depth interview in NHANES often gets you closer to an accurate answer than other interviews. So we generally find that web or phone data collection will get you one level of accuracy, an in-person interview closer to accurate, and then the HANES in the exam center interview even closer. An example of that is weight. Weight is consistently underestimated on the phone for some reason. It is significantly less underestimated when you're talking with somebody, and it is quite accurate when you're about to weigh somebody. So there are a whole host of things that are measured that are relevant to educational, agricultural, and other spheres. Ed?
Well, because, and just on that last point, because we ask people what they weigh and how tall they are, and then we actually measure it, this enables us to understand those differences, which then can be used in a wide variety of different surveys. The kind of example that you gave, at the community level. But there are other things that come out of NHANES. There's, as Dr. Frieden mentioned, there's all the nutrition information and the foods, exactly what people are eating and how much of it, and when they eat it. There's information on size, how big are people. Okay? Very, very important information that's been used in the past. As I understand it, people who designed airline seats use this information in the past. Don't blame us now.
I'm sure that was a great example.
That's right. That's right. I'll think better of it next time. But I understand that it's a very important source of information. Another area that is both related to health but also outside that is in exposures to chemicals. NHANES is the only nationally representative bank of exposure information that looks at individuals as to the extent to which they have been exposed. Other data sources look at where the exposure is coming from, and they tend to be very localized. But this gives us a national picture of exposures.
And I'm glad Ed mentioned the exposure data. There are hundreds of analytes or contaminants, everything from pesticides to BPA and other things that you read about in the news. The definitive information about that comes from NHANES. It's analyzed largely at the laboratories at CDC. Our environmental health lab, as an example, does on average 3,400 tests per day, of which only a minority are actually from NHANES, but NHANES is a significant part of that and then releases periodically and now updates on the web as it's available the definitive information on chemical exposure. Just to give a little bit more detail, the National Institute of Occupational Safety and Health, NIOSH, has worked with truck manufacturers to change the cab of trucks to better fit for safety and ergonomics based on, I believe, NHANES data. So, and the industry is very appreciative of that kind of information that allows them to have a better product that's safer and more comfortable and causes less work-related injury. You want a sample that's representative of the United States population so that we can extrapolate from the 5,000 people that we've examined what the health of more than 300 million people is. We've had challenges because of minority populations that we may not be able to sample adequately to generalize to that population. So we've been able in NHANES to have information for African Americans, information for Mexican Americans, and for the first time we'll be able to have nationally representative information for Asian Americans.
The creation of the sample is really statistically complex. What populations do we want to, the term is oversample, so that we, rather than pull together a sample over many years, we can do it over a very short period of time and give us a more complex or complete picture of the health of that sample. But people take the techniques, just as Dr. Longjohn mentioned, they take the techniques, the measures that are used, and they apply these in specific locations. It's happened in New York City, but it's happened in the state of Washington, in Oregon, in a variety of places in the country where people use the methods, okay, to hone in on the populations they are particularly interested in. And I think that's a really important part of this, that the study just doesn't stand alone. It really has to be viewed in terms of its impact on biomedical research, on public health research. And that comes from the methods and a variety of other areas.
I would guess that you probably don't even know all the places
No,
that it's used, right?
Absolutely true.